Good afternoon, everyone. My name is Mike Strozinski, Senior Vice President and General Counsel here at the Massachusetts Health and Hospital Association. On behalf of the entire team here at MHA, I'd like to welcome you to today's webinar, Who Will Care for Healthcare? Changes in Antitrust Enforcement. A few logistics before we start. If you have questions during the webinar, please enter them into the chat feature as we are in a listen-only mode. The questions will come directly to us, and we'll do our best to address as many as we can at the end of the presentation. And I also know our presenters will pick some up during the presentation as they can. I also want to take a moment now to thank MHA's 2023 sponsors for their support in underwriting today's webinar, which is just one of many events we offer throughout the year to connect our members with leading experts on timely issues like this one. I'm now pleased to introduce the speakers for today from our member law firm, Locke Lord, LLP. First up is David Szabo. David represents hospitals, integrated delivery systems, physician organizations, home care companies, and other healthcare service providers. He also represents healthcare information technology companies and health plans. He's co-chair of the firm's healthcare practice group, a partner in the corporate and transactional department, and a member of the privacy and cybersecurity practice group. He'll be joined by Joe Farside. Joe has a multi-jurisdictional litigation and counseling practice, and he routinely appears in state and federal courts throughout the Northeast, in addition to proceedings involving the FTC, DOJ, EPA, and OSHA. He has deep experience in areas of antitrust, environmental, and litigation. Thank you both so much for being here today, and we're looking forward to this discussion. To get it moving, I'll now hand it over to David.
Great. Thank you very much, Mike. We appreciate it and appreciate the opportunity to be here with MHA today. I'm not sure who all is signed on, but some of you may know me. Dave Szabo. I've been involved with MHA for many years, but I'm guessing that fewer of you know my partner, Joe Farside. I've had the privilege of working with Joe over the last few years on a number of healthcare transactions. And I'm pleased to say, despite the difficulties put up by the government, some deals actually do get done. And Joe's been a big part of helping my clients do that. But it's a very rapidly changing area in terms of the views of federal and state government on healthcare transactions. And I'd say skepticism is one word for it right now. But this is really predominantly Joe's presentation today. And he's going to go through recent changes at the Federal Trade Commission in their processes and their substantive views and how they affect our ability to enter into and complete healthcare transactions. So with that, Joe, I'm going to turn it over to you, and probably we should go to the first slide in the package.
Thank you, Mike and Dave, for the kind introduction. Like Dave said, very happy to be here with you today. Dave and I have worked extensively, and I have many thoughts about the intersection of antitrust and competition law and healthcare. I could do this presentation all day, every day. I will do my best to fit it into the time allotted and hit the pertinent points, and happy to answer any questions. Some of this background is going to be obvious to you, but we've worked on mergers, transactions, joint ventures, affiliations that are tight and loose and everything in between. And we understand all the reasons why those are important to your industry. What I can say is that at this point in time, we have no faith that state or federal antitrust regulators understand these benefits, nor do they have an appetite to delve in to any specific circumstance and accept these transaction rationales as being able to justify consolidation in the industry, which for our clients can be very frustrating. We go to the next slide, please. So the overview of the changes that are taking place are set forth on this slide. We, as a healthcare industry, are going to be focused upon to mine and provide a significantly more amount of information when you're attempting a transaction that's subject to state or federal regulation or antitrust review. You're going to have to factor in additional time, cost, and burden And the last bullet here might be the most important, the sequencing around when healthcare system, hospital group brings in its antitrust counsel and economists to advise them the likelihood of success of a transaction, affiliation, joint venture, probably needs to be moved up to the top before any system spends significant time and resources pursuing any particular affiliation or transaction. So we'll get into this in more detail. If we go to the next slide, please. Quick summary of the antitrust laws as I view it. There are sort of two major umbrellas. One umbrella covers conduct between separate entities where they get together and improperly fix prices or bid rig or carve up a market, or where a single entity grows so large that it abuses its monopoly position. And we give the example here that we get asked from time to time, and it's a rational question, but you can't behave this way. Hospitals A and B cannot agree that hospital A will handle certain services and hospital B will handle other services, and that they'll otherwise stay out of each other's way unless those hospitals are part of the same healthcare system. Even then, it's a challenge, but that gets you much closer. Next slide, please. The second overarching concept in antitrust is that it prevents mergers or acquisitions where the resulting combined entity has too much power in the eyes of the antitrust regulators. And we give the example below of you have hospitals A, B, and C in the same city. Hospitals A and B get together or want to get together, but at that point, they're going to have, let's say, 95% of the patient discharges in that city. There's a pretty sure bet that that will draw heavy antitrust scrutiny and will probably be blocked, because the argument is they'll have so much power over patients that they'll be able to also then dictate terms to health insurers. Next slide, please. So it's that second example that we're really going to dwell most on today, which is the in the transaction, affiliation, joint venture setting, where growth other than organic growth, let's put it that way, where you're going to see the heaviest scrutiny based on these current changes. So a component of helping that scrutiny happen is we have a federal law called the HSR Act. And the prior example I gave was Hospital A and Hospital B merging and having a predominant share of the patient discharges as a result of that merger. What the HSR Act does is it requires reporting of those kinds of mergers in significant detail to the Federal Trade Commission and the U.S. Department of Justice before that merger can close, so that those agencies have the time to review whether a proposed transaction would in fact violate the antitrust laws before it closes. And that's because historically, before the HSR Act was passed, these anti-competitive transactions, not just in healthcare, but any industry, would be closed for over a year, and then it would be very difficult for the FTC or DOJ to convince a court to sort of unscramble the eggs, if you will, and make those two formerly separate corporations separate once again. And as you can see, there's a little bit of a carrot at the bottom, that there is a $50,000 per day civil penalty if you close a deal without complying with the act. Next slide, please. So setting up the basis for the reason why you will care about some of these changes and the intense focus on healthcare. You may already know some of this, that the FTC has succeeded in blocking dozens of hospital mergers, physician group combinations, and joint ventures over the last 15 or so years. Really, we think that it's the roadmap for the federal agencies to follow in attempting to block a healthcare transaction has become so clear to them that they pursue it because it's a path of least resistance for them. In other words, it's easier for them to seek enforcement in an industry where they have momentum and a roadmap to follow than in other industries that they don't understand very well. We now have a follow-on effect of state attorneys general realizing that they can score political wins, at least in the eyes of some stakeholders, by attempting to be part of the anti-healthcare consolidation movement. And what we're seeing is that this is not limited to any one political party. In fact, a lot of the enforcement against healthcare consolidation accelerated during the Trump administration, has become even more intense during the Biden administration, and we have faced stiff investigations and resistance from state attorney generals of both parties. And as we say in the last bullet, we realize that this is harming evolution in your industry, and even preventing other federal policies and laws like Obamacare from being able to have their full effect. Next slide, please. So first, I'll cover a substantive change from the perspective of the Federal Trade Commission and Department of Justice that happened this year. There was previously longstanding safe harbor guidance that recognized the value of certain joint conduct amongst healthcare providers, and without blessing it in the eyes of a court, signaled the agency's approval of that conduct as being pro-competitive, and therefore it avoided scrutiny. With the revocation of this safe harbor, there is now a large new area of uncertainty about how the Department of Justice and FTC will treat many kinds of cooperative efforts between healthcare providers, or that just involve healthcare providers. And we list a couple here: MSOs, joint ventures. But the take-home message is in the final bullet here, that the agencies have decided that their fears that these kinds of coordinated efforts in the industry have a risk of improper market collusion or the sharing of competitively sensitive information, and that fear trumps the benefits in their eyes of those collaborations. And this is a good place for me to kind of give you the perspective of a federal or state antitrust enforcer in the healthcare space right now. If two parties get together, if two providers get together and share their assets and resources to create a new specialty medical service that neither of them can offer on their own, that should be the hallmark of a pro-competitive joint venture, and that frankly we think would pass muster. But an agency lawyer looking at that is going to assume out of the gate that that joint venture is being done for some nefarious purpose of sharing competitively sensitive information or maneuvering the market in such a way that will benefit those parties in terms of higher rates for medical services. It's a very unfortunate view, and it doesn't seem like it's going to be fixed anytime soon. Next slide, please. So that was a substantive change that directly impacts healthcare. I'm going to focus for a while now on important procedural changes that are going to have a disproportionate impact in healthcare. As we mentioned before, the HSR Act governs how the agencies receive notice of proposed transactions in every industry, not just healthcare. New rules, sweeping changes were proposed this summer that are going to become effective either later this year or very early in 2024. And whereas we previously could have prepared and submitted a filing with 2 weeks or so lead time, we're thinking that for a typical healthcare transaction, it's going to require at least 3 months, and it's going to increase the cost of preparation by 10x. More on that to come. We go to the next slide. We drill a little bit more closely on the differences, the practical impacts on you from these changes. We already mentioned the prep time. One advantage in the current regime is that you're able to file on a letter of intent, a very simple non-binding agreement, and that's going to change, which will impact how deal negotiations happen before a filing is made. It increases, the new rules will increase the risk that the FTC and Department of Justice will not accept the filing as being complete and come back to us for more information, thus delaying the start of the 30-day waiting period. And then, of course, we'll be giving them a substantially more information at the outset, and we expect that they are going to need more time to review that and therefore extend the waiting period by issuing second requests more frequently. That's the only logical outcome of the sweeping nature of the proposed rules. Next slide, please. So these rules were the FTC's answer to the problem that Congress failed to pass sweeping antitrust reform legislation during the first 2 years of the Biden administration. That's what the Federal Trade Commission lobbied hard for. When they did not receive that new legislation, they decided to legislate by regulation and regulate by intimidation. The new rules essentially make it so burdensome and change the goalposts in terms of just submitting these pre-closing filings that parties, and in particular in healthcare, but clients in every industry, are going to have to take this into account at a different time in the timeline, at a different point in the timeline of doing their deals. We go to the next slide, please. So to put an even finer point on this, the changes to the HSR Act implementing rules are going to require things like detailed competitive analyses of numerous different kinds of healthcare services that are implicated by the transaction. For a hospital system that offers inpatient services, acute care services, specialty services, also offers PCP services and employs physicians, and also has its own outpatient facilities, and also employs healthcare workers, it's going to require intensive work to prepare a narrative describing those sectors of the hospital system's business. And in the very act of preparing those narratives is fraught with risk. Further, healthcare systems are going to have to provide narratives about the geographic service areas, and as all on this call probably know, that's not a cut and dried exercise either. And going back to my point about employees, we all know very well that healthcare systems employ all kinds of employees across many disciplines, varying levels of those disciplines, and the extent to which we're going to have to work with our clients to summarize and disclose all those groupings of employees remains an open issue, but a huge burden nonetheless. Next slide, please. This one is self-explanatory. Right now, there's no requirement to disclose lenders. If you have bondholders or lenders that have more than 10%, hold options or warrants, or have even veto rights, we are going to have to start disclosing those types of entities and individuals. And of course, management agreements could come in many forms and impact your governance and your operations in many ways. So having to disclose those firms with management power, and then dealing with those firms and alerting them that you're going to be disclosing them and that they'll probably themselves be hearing from the government, is likely to cause some consternation in this process. Next slide, please. And we're going to take a break here in a moment so we can take some questions in the interim after slide 21. This I find extraordinarily invasive, that we will now be required to identify officers, directors, and board observers. And that's up and down throughout the healthcare entity. And that might include, for example, if you have a subsidiary that's an LLC holding employed physicians that has a board of those or members who are those physicians, those folks will now have to be disclosed by name. And you're going to also have to go back and list the names of folks who are not currently in such role, but have been within the last 2 years. It's unclear how this information will be used, whether the FTC and the DOJ are looking to build a database of board members in order to see who is sitting on what boards to determine overlap in that regard, or if they plan to call these directors in the pre-closing period and ask them questions. That is all still unknown. And as I say here at the bottom, we're concerned about an individual's willingness to serve in leadership roles when they learn that their name will have to be disclosed in an official filing to the Federal Trade Commission and the U.S. Department of Justice. Next slide, please. This slide is probably a little out of place and should have been 2 slides, should have appeared 2 slides before, and that's on me. This just gives additional areas where narrative descriptions will need to be prepared from scratch, whereas under the current HSR regime, we do not prepare, we prepare only a very minimal amount of text from scratch, which essentially describes the transaction in a paragraph or 2. What the FTC and DOJ are asking for now will be more akin to what they ask for and receive in a intensive second request setting. Essentially, they're getting that information during the initial waiting period. Let me pause there and see if we want to take any questions or folks have questions before we turn to practical advice about documents. Hearing none, and I think there are none in the chat. I'm not the world's best operator of Zoom. I will continue to move on, and you can feel free to interrupt me at any time. The next major difference in the rule changes around the HSR Act concern the scope of what we call HSR Item 4 documents that need to be submitted. These are documents that historically have only related to the transaction at issue and only final versions of those documents. For example, if executive management prepares a 20-slide deck explaining why a hospital acquisition is in the best interest of the hospital, and they present that to the board to ask the board to approve the acquisition, that's a bullseye for the type of document that would have been provided under the current regime. We were able to limit the scope, and it was still burdensome even at that. But we were able to follow established guidelines that look for a narrow tranche of documents. Of course, now the Item 4, the universe of Item 4 documents is expanded both in terms of to documents beyond those that are prepared solely for the purposes of a transaction, but also to drafts of documents. In the past, it was a hard rule that you only needed to provide the final version of a document. And as you probably know, a slide deck asking the board to approve a transaction might go through 20 or 30 drafts. But the new rules will require even those very initial drafts. And we view this as a huge burden. And you're also going to have to add for each document additional detail about the authors of each document. The biggest concern with, and let's go to the next slide, please. I'll cover these topics first. Expanding this scope of the Item 4 documents to ordinary course periodic planning type documents, as well as drafts, means that the government will have an easier time capturing documents that have not ever been reviewed by a lawyer, let alone an antitrust lawyer. So under the current regime, the process was antitrust counsel is retained. We would advise the folks drafting documents in support of a transaction to just show us drafts before they're made final. At that point, we're able to have discussions about clarifying certain language or hopefully avoiding certain buzzwords that were unintentionally used to describe a market or competitors that might harm the transaction's likelihood of surviving scrutiny. And those types of things could be cleansed or made more accurate before those documents were made final, and the government would not see those drafts. Now, either we have to live with the fact that those earlier drafts where care is not taken as much in the drafting and live with it, or counsel, whether internal or external, will have to be consulted at the very beginning of that drafting process. That's going to be tougher with respect to ordinary course planning and reporting documents, where even under these new rules, we don't expect our healthcare clients to pay for counsel to review all of their documents before they're sent up to the CEO or the board. But we perhaps can work on some training to help in-house counsel and executive management be alert for these kinds of pitfalls. Let's go to the next slide, but I do see that there's a question in the chat. And the question references governance, and the question is about if I think the scrutiny about governance might also apply to M&A in the healthcare sector. And I absolutely do. I want to invite Dave to participate in the answer here as well. But we have fielded more so from the state attorney general level than the federal level pretty intensive questions about governance. Dave, do you want to add to that?
Yeah, Joe, well, first of all, to Joe Farside in answering Joe Driscoll's question, yes. I mean, more so at the state level. But I think there's an intense interest at the FTC more about how decisions are made. Part of that, I think, is instigated by the role of private equity in healthcare. We're working on a kind of a white paper about changes at the state level across the country. And a number of states have actually, for example, published guidance that says they want advanced reporting of any transaction involving a private equity fund, which is very unusual. And as you might be aware, probably are aware, those funds tend to be extremely private. So kind of shining a flashlight on them is going to be kind of a slap in the face to some degree. They're going to have to adjust to. But certainly at the state level, we have seen a lot of scrutiny around how decisions were made, what the board has been told, how their decision-making process has worked, and what other interests beyond competition they have considered. And I think maybe when we get around to talk about guidelines and things, I think a number of deals have stood or failed based on state level review of issues that have nothing to do with antitrust, but get all tangled up with the antitrust review. And we can get to that. But I think the short answer is yes. And Joe, I'm going to let you continue.
I'm going to give one example because I think I understand Joe's question a little bit better from my perspective. We had a recent healthcare transaction where it involved a university that was going to be supporting the combined entity going forward in terms of academic medical center type initiatives. And the Federal Trade Commission and the state attorney general involved could not be convinced that what was really happening was a takeover of the hospital systems by the university. That's a microcosm of this issue of governance and who controls what. The clear lines of control under the current HSR regime are giving way to more blurred lines of control. And that will be a whole other part of the pre-filing analysis in terms of who controls what under the new rules, the new flexible and liberal rules. So it's a really good question. Moving on to slide 24, this is more about technical compliance. This is putting all parties on notice that when you harvest these item 4 documents going forward, you're going to have to scrutinize all the media through which your business communicates. And that includes text messages. And that includes text messages on your personal iPhone with other people that you work with that relate to business. That is incredibly invasive, but we know from experience over the last 5 years, the FTC in particular is convinced that when they are looking for bad conversations, looking for conversations about market dominance or wanting to exert leverage over a payer or wanting to control the physician market, they're finding those types of things in text messages, not on formal email. So it's extremely burdensome. We have methods to make it less burdensome for the individuals, but it's still sort of shocking to have to search your individual cell phone for text messages. Next slide, please. So a lot of this stuff is self-explanatory. What does this mean for your hospital system? And we touched on this at the beginning. The last 3 bullets, I think, really harm your industry. And that's because many of our healthcare clients are the most earnest, well-intentioned clients there could be in terms of wanting to help their community, wanting to recruit better physicians, wanting to expand local care, wanting to reduce costs, because that's what everybody wants in healthcare, and do not have the resources to get into a compliance fight with the FTC or DOJ, to take the FTC to court because the FTC is abusing its power in dragging out an investigation over technical details of compliance with producing documents. And what that leads to is inevitably a point in time where a hospital client or healthcare client decides that just preserving the status quo is a better approach than continuing to spend money and time with an uncertain outcome fighting an agency like the Federal Trade Commission. And that's really disappointing. And I believe it has a disproportionate impact on healthcare. Well-heeled Fortune 50 company like Facebook can fight those kinds of fights, and it makes no difference. That's not to say every healthcare system wouldn't or couldn't fight, but on average, it's very difficult and it becomes very expensive. Next slide, please. So with all of that said, key factors to take away from this. HSR compliance and antitrust reviews can no longer be done at the end of a transaction negotiation. It has to come earlier. You have to plan that there will be 3 months of lead time before HSR can be filed. We're going to need more of your help to prepare those filings. We conservatively estimate that the cost of submitting an HSR filing, even in a run-of-the-mill transaction, is going to cost around $250,000. And that doesn't even account for a potential second request. Second request will, if you haven't been involved in one, will take you into the millions of dollars. Next slide, please. First bullet we've covered. Now, the value there is the board is interested in an acquisition of healthcare system or hospital B. Can we do it? Will it work? Or is this going to be a total waste of time? That's something that an economist and antitrust lawyer can tell you in the phase where it's being conceived, as opposed to when you're trying to close it and you're stuck in a deep investigation that you didn't prepare for or didn't foresee. And that in and of itself is not an exceedingly expensive or time-consuming endeavor. Over a couple weeks' time, with some pretty basic and available information, that analysis can be completed and discussed at the executive or board level.
Joe,
Next
maybe
slide.
I could just jump in on that one.
Sure.
It's especially useful or one of the settings is if an organization is potentially thinking of more than one partner in doing some kind of transaction. What on the corporate side, for-profit side would be called the sell side of a deal. And you're saying, well, who's the best? I think you can investigate who's got the most financial strength, who makes the most enticing proposition. There could be other factors you look at. But, we were in fact instructed by a client to say, you have to also give us a preliminary, what they called legal feasibility analysis. Is there somebody who we think might be attractive from a business point of view that will simply never be allowed to do a deal with? And I think with the amount of consolidation that's already occurred in certain places, and with the increasing skepticism of the government, I think it's incumbent to kind of do that legal feasibility analysis early to say, who would we be allowed to do a deal with? And maybe save yourself a lot of angst down the road.
And trust Dave and I, it's hard to tell a client that a party that they feel enthusiastic about, at least preliminarily, will never happen. But we know then when they embark on a different transaction that they know with certainty, or not with certainty, but they know with a much better level of confidence that it will happen. Next slide, please. These are more Dave's bailiwick, but there are impacts that these rule and process changes will have on transaction negotiations around what happens in the time prior to closing, what each party's obligation is to comply with these new rules, vague as they may be, what happens if the deal falls apart or gets blocked, and that accounts for the uncertainty in the timing from where we were previously. Finally, we know that healthcare transactions have are a major drag for internal morale and employee retention issues, dealing with payers in the meantime. And, there are things that can be done to prepare those stakeholders for the process. Next slide, please. This one, I think, is, to me, the advice I've given over my 17 years in antitrust and working in antitrust compliance and on HSR process. Document drafting means everything. If you have a transaction you want to do and you produce a set of 24 documents that avoid antitrust buzzwords like leverage and dominance and market control, and explain all the good intentions and good things that your hospital or healthcare system are doing, you're going to have a significantly easier time getting the government to believe that an affiliation or joint venture or transaction does not present serious competition law concerns than if you present documents that inadvertently contain that kind of language. And again, in the past, we were able to kind of filter that through the antitrust lawyers later in the drafting process, but now more care will need to be given earlier in the drafting process. Next slide, please. Well, I have a habit of getting ahead of myself. So on this slide, you can see more granular detail about what we want to avoid in document preparation.
Let me just add a little more to that one. That first bullet. I've worked occasionally with folks, especially maybe internal strategic planning folks, that may be over-enthusiastic about defining competitors and identifying, someone who's really on the periphery, far away, or really in a different line of business. Well, they're a competitor or a potential competitor. That can have legal significance, and you have to fight against your own documents. It's a lot harder. And also defining the market, that is sometimes the crux of getting some progress with the government. What is really the geographic market? What is really the service market, especially geography? And if, someone says, well, our market starts at the Atlantic Ocean, it runs to the Pacific Ocean, and it goes up to, the Canadian border, you've created different issues than if the market isn't defined until people have done some real analysis. So just say sometimes your internal documents can be a little problematic, even with the best intentions, and without trying to create any trouble whatsoever.
Oh, perfect. Thank you, Dave. If we can move to our final slide, I think the need to consider antitrust training is going to be escalated higher now more than it's ever been. For a pretty modest investment of time and money, senior executives and business leaders can be educated as to some of the things we just talked about and the risks of document preparation and being accurate and avoiding controversial content in all facets of their employment, not just when dealing with a transaction, but in ordinary course business document preparation, analytical and research summaries and the like. And that training doesn't have to be a one-time only. It can be periodic, and it can be married with 1 or 2 page straightforward written guidance that folks can keep handy and can be refreshed by the in-house legal team periodically. And that would go a long way to, like David said, not sort of fighting against yourself when it comes time to do an affiliation or joint venture that is going to improve the care and the services you can offer to your patients. So that concludes the formal part of our presentation on antitrust changes. I'll turn it back over to Mike.
Thank you both. A lot of great information there that I know our attendees here today will be taking back to their organizations. Running a little long, but just want to offer, if there are any last minute questions, please enter them into the chat. And maybe just let me leave you both with one, if you got a quick response. What do you see as the end game of this increasing focus from antitrust enforcers in terms of impact on the ability of hospitals and physicians to operate and evolve?
It's a great question. Dave and I have had a number of long conversations about. Right now, we have to accept that consolidation and affiliations in healthcare are all viewed skeptically to begin with. So you're guilty until proven innocent. At some point in time, this sort of crusade against healthcare providers through the antitrust laws is going to start to harm people and harm political careers. And, health insurers are going to have to accept that for physicians to work, they have to be able to get even a modest pay raise. They have to be able to be paid for the amazing work they do. Hospitals have to be able to, pay all the staff members they are required to have, not only to provide patient care, but to comply with all of the layers of regulatory requirements. So it's really a conundrum where, on the one hand, expenses are out of control due to market and regulatory forces, and on the other hand, the government views all attempts to control those costs negatively. So I don't have an answer for what the end game is, except that at some point the balance is going to have to shift, because otherwise the healthcare system is going to function even less properly than it is now. Dave, you're on mute, Dave.
I tell you, it's going to be on my tombstone. He was on mute. Just a couple of quick things. There's a lot of schizophrenia in the system, and we see it all the time. For example, the safe harbor protections for sharing certain economic data or pricing information, for example, under certain controlled circumstances, has been repealed. At the same time, the Affordable Care Act says, post your negotiated prices on your hospital website in machine-readable form, okay? Is that a crime, or is that legal compliance? Hospitals that need to rationalize, maybe looking at certain services that are just not sustainable because of Medicaid rates and other factors, right? The government howls bloody murder and for understandable reasons, but yet they oppose things that would make the system perhaps more sustainable. There are other, Joe and I went through a process of dealing with the government on a particular deal when their big concern was the merger would harm employees and allow the two hospitals to push down wages. And we said, we're in the middle of a crisis where in some cases they can't hire people at any price. What are you talking about? And kind of a system using old data and divorced from reality. I think, maybe it's just a simplistic idea. We've got to communicate better about what some of these issues are and have a higher level of understanding. But that's going to be challenging because I think people have, to some extent, are just reading a comic book with the FTC coming in as the hero. And it's not very much related to a lot of reality. So with that, I think we have a new message. But I'll stop. It's a message for you guys. So thank you, Mike.
Well, a message for you guys. David, Joe, you okay with sharing the slides with the participants today?
Absolutely.
Yep, I agree.
Yeah, so we will. And first off, I want to say thank you, David and Joe, for leading a great session here today. And certainly want to thank everyone watching as well. We'll be sending out a follow-up email with the slides. And also with a follow-up survey that we hope you take the time to fill out and helps guide us as we present future webinars for you all. You can also scan the QR code on your screen now, which should be popping up, Nick. And if you do, you can see the full slate of events coming up this fall from MHA, all of our educational programming. We hope to see you soon at one of those or at a different MHA event. Thanks all for watching today, and hope everyone has a wonderful afternoon.
Thank you.
Thank you.